This is on interpreting microbiological test results, and I'd like to invite Sanchia Warren to the stage. So Sanchia is an infectious diseases physician and clinical microbiologist at the Royal Hobart Hospital and a senior lecturer at the University of Tasmania. Her interests lie in antimicrobial stewardship, where she is the clinical lead for AMS in Tasmania. She is also on the writing group for the Royal Australasian College of Pathologists Selective Reporting Guideline for Laboratories. Say that 5 times. Thanks, Sanchia.
Yeah, points to you, Madeline, for getting that last sentence out. It is a bit of a mouthful, and I'm going to just touch briefly on that when I talk today. So just to put this into context, this is a totally new piece of information, a new chapter that's gone into the guideline, and it isn't really aimed at our audience, majority of our audience here today. It is aimed at those junior doctors and those people working in rural areas that really use these guidelines as the principle and the basis of their management. And so it's putting a little bit more information and context into microbiology results for those people so that they can make the right selections as they move through the guideline. So it really comes down to, why do we perform tests? We all know this. We want to select the right antimicrobial for the indication. And so we've already heard a lot today about empiric therapy, and a lot of the therapeutic guidelines is about empiric therapy. But when we're interpreting our microbiological tests, we need to consider that we're moving towards directed therapy. And so that's mostly what the panel discussion has been about as well, that we're starting to think about directed therapy and how to best dose these. We want to use our test to select the right antibiotic. We want to ensure that we're using timely review of our tests. As I said, we're moving empiric towards directed. We always want to try and aim to use the narrowest spectrum agent that is practical, a single agent if possible, and this is really the basis of the Australian Commission of Safety and Quality in Healthcare's antimicrobial stewardship clinical care standards. And so I've cut this slide up to really show us what those clinical care standards are, but there are 3 that really relate mainly to when we're interpreting microbiological tests, and that those are 4, 6 and 7. So we want to do tests so that we take those preferably before we start antimicrobial therapy, but not always practical, and that's going to guide us. We want to document what we're doing and why we're doing it, and also why we're selecting that drug, so that may be related to our antimicrobial testing. And then also we need to review our therapy. So we all know that it's not a one-stop shop, it's not one antibiotic and we keep it ongoing. We want to be reviewing this continuously. So the tests in this are really important for that. You all know that a pathology test has a life, and after it's been collected it goes to many, many different places, and it's all important when we're thinking about selecting our right antibiotic and how we're going to interpret those tests. And so this is the life cycle of a blood culture. It is long. There are many places where it can go wrong, can be delayed, but you can see that it takes quite some time for us to obtain a result where we can start thinking about directed therapy, and that we need to, through that timeline across the top there, we need to continually think about what antibiotic we are using, and using the information that we have available that is going to change over those, sometimes even out to 5 or 6 days, to target our therapy. So just a little bit of background, I'm sure you're all pretty au fait with this, is that there are antimicrobial susceptibility testing is undertaken using standardised techniques. And these are CLSI and UCAST that you've heard a lot about, and they allow us to interpret a clinical breakpoint, which is when we see on our report an S, an R, or many other letters of the alphabet I'm going to touch on shortly. And these have been in the chapter. We actually also do mention CDS, and that is, as most of you know, it's on its demise, but it is still referenced in there, but I'm not going to touch on that today. So these are developed using pathogen drug combinations, and between CLSI and UCAST, lots of information is used. It's research, it's historical knowledge, it's clinical data, PKP PK/PD data, and they approach it slightly differently, but I think we're all starting to move in the same direction with these. There are many different methods, we know this, and in this chapter I try and mention a few of these for those junior staff. I think it is important for them to at least be aware that they're not just getting some letters, an SNR at the end of the day, and there are different mechanisms and they do have slightly different meanings. So here we've got susceptibility disk testing, we've got a gradient strip, depending on what supplier you use, whether you can use the term e-test. And then we also have here, this is a Vitek AST testing card, which allows us to undertake broth microdilution. So this is just a little, very simple table showing us the difference between CLSI and UCAS. I really have kind of summarised it very briefly here. They're basically developed by committees, so a group of people. And for CLSI, the breakpoints are based on commentary, resources and studies, and it includes in vitro PK/PD data and clinical studies based on those. Whereas UCAS differs slightly, that it's using defined doses, considers the site of infection associated with the PK/PD and the organism. So for each different organism, it's sort of a little bit more directed to that antibiotic organism combination. There are now rationale documents for breakpoint changes for both situations, and UCAS also includes some rationale documents for clinical scenarios. So in the latest iteration, there are now breakpoints for endocarditis, and there is a rationale document discussing endocarditis breakpoints. And CLSI has always been at a cost, though this is kind of changing and becoming more freely available. UCAS is freely available to everybody on the website. So also in this chapter is what is a breakpoint. We throw the term around very, very easily. And so it's really trying to make that simple for the junior doctor or the GP who's working in multiple different practices to really understand what they're looking at. Really it's just a system we use to categorise our microorganisms where we compare it to an antimicrobial and say whether we can use that antibiotic or whether we have to do something in between. And so just here very quickly is just what the breakpoint table looks like. It obviously extends well off the page, but you can see that it's getting increasingly complicated for different situations, in particularly Enterobacteriales and the aminopenicillins. So purple is CLSI and green here is UCAS. And when we're talking about susceptible and resistant, so is it going to work, is it not going to work? I've included these definitions, or included the definitions in the chapter, and I think it is important to say that really they're kind of saying, at this dose, at a standard dose in UCAS, you're probably going to have success. And then resistant is you're unlikely to have success. But where we get complicated is all those letters in between. And I think it's important, and it is iterated in the chapter, that people should ideally be aware of what method their laboratory is using. And if you think about a GP, they could be using multiple different pathology providers. The reports are going to vary quite substantially in what they report, how they report it, what comments they might add. So in there is trying to point out to people it is kind of important to know what kind of testing is being undertaken. And so here you can just see the difference between susceptible dose dependent and susceptible increased exposure. And depending on your laboratory information system, so your computer program that's doing this, is whether you can actually release SIE, whether you can release I. It may not be able to actually fit the letters in. So all of this comes with complications, but it tries to explain that through the chapter. As Madeline mentioned, I'm on the RCPA's selective reporting writing group, and we're just about finalised our latest revision of that. Fortunately or unfortunately timed with the release of therapeutic guidelines. We signed off on it on Friday, but I suspect we'll have a few more conversations. So selective reporting is where when the pathologist ideally reporting out this, when they're reporting out susceptibilities, is trying to give information on the narrow spectrum agent indicator of that indication. So it's got to be an antibiotic that's going to work. We ideally should be providing alternatives in the case of an allergy. And then we're trying to also not give broad spectrum options. We're trying to save those options and make recommendations about what we should be reporting out for those situations. And all of this is going to be impacted whether your computer program again can do that. And I'm fortunate, I work in a laboratory where we use something from essentially 1972, and we have the ability to even order our antibiotics and choose what we select. But some places have to have sort of a standard reporting. But the idea of selective or cascade reporting is that we're trying to give narrow agents an alternative and save those broad spectrum antimicrobials. And so it does mention this in the chapter. It also discusses very briefly how to interpret a microbiology report, preaching to the converted here hopefully, but it goes through simple things like look at the sample type, what was actually sent, look at the cell count, is it high, does it support infection, and look at the gram stain, because the gram stain is going to start leading you down that directed therapy path potentially, but also make you consider that you might need to keep a broad approach to your antimicrobial. It then says simple things like look at the organisms listed. It sounds simple, but I know that most of our interns can't interpret mixed cultures particularly well. So really look at what's there, look at the antimicrobials that are lined up against that pathogen, and look at the comments. So for the microbiologists in the room, I know we spend a fair bit of time trying to consider what comments we are putting on those reports. We know they're not read. We know because we get many phone calls, and some of the answers are please just read what's below. But we do try and give information about dosages, management plans, and particularly even just then I was sitting there thinking, we've got to potentially, we have a Haemophilus comment, we should be modifying that, making sure we're getting the dosing, the ceftriaxone right in there, give people information. Because it's not just as simple as putting out an S, an SIE, an SDD, an I, or an R. So I've got a couple of little microbiology results here. I will just go through them quickly because they are going to be hard to read. But really, it's just to say, there's lots of information on the report. It tells you it's an infection. It's got leukocytes. It's polymicrobial. And the thing that I wanted to highlight with some of these is that not everything is going to grow. And that is mentioned in the chapter. Look at the gram stain. Anaerobes can die, and you may need to still consider treating those. This here is a mixed infection. You can see that we've used cascade reporting, so we wouldn't have necessarily reported out some of the broader spectrum agents, except for the fact they were resistant, so just ciprofloxacin, that would have been reserved, but we will tell you it's resistant, and obviously trying to give alternate agents if you've got a beta-lactam severe allergy. This here is a urine result. Again, does it look like an infection? What is the organism grown? And then what options have you been given here? You can see here that in this setting we use cascade reporting, and we're pretty harsh. And so we've only given them trimethoprim as an option, and then we will expect a phone call. And I have added this one in. So this is an example of SIE. So you are going to see, depending on what laboratory system is used, that you will not just see an S or an R. And we provide the definition of what SIE is below that. And also this is the UCAS dosing for this indication. So we've got to remember here, we're now talking about directed therapy for this setting. And again, often these comments aren't read, but it is important, I think, to provide that information and people to be aware that it often is available for medical staff. This is what our laboratory system, even though it was built in 1972, couldn't fit in multiple letters. So previously we had to report this as I and then have the definition below. And then finally, this is looking at essentially comments. So basically the bottom one down there is saying that we don't perform susceptibility testing routinely for a Strep Milleri group. And so this is where highlighting the comments are important and that people should be reading them, because they might be waiting days to get an S or an R, and we don't provide that, and that is in the selective reporting guidelines. Some laboratories will test, and it will depend on the isolate and what the clinical situation is, but that's there. So the idea of the chapter is really aimed at GPs, junior medical staff, people who are out there on their own, gives them a framework and hopefully gets them more familiar with what's happening in laboratory testing. I think in hospitals we get pretty spoiled. We often have our microbiology teams on tap, or at least able to contact them easily. But for a lot of people out there, therapeutic guidelines is like a Bible, and it's really good to have a framework for them to be able to approach their testing. Thank you.